Hello and welcome to this lecture. Today we are going to discuss myocardial infarction, and I am giving you a case presentation of a 61-year-old man present to accidents and emergency with a 30-minute history of severe chest pain. The pain was of sudden onset while the man was at rest in his armchair. Reading the newspaper, the pain is central and radiate up to the jaws. On examination, the man appears unwell and frightened and is pale and clammy. His pulse is 112 per minute and regular. His blood pressure is 160 systolic and 90 diastolic mmHg, and electrocardiogram determined the myocardial infarction. So what are the learning objectives we have in this case? We will need to define myocardial infarction. We will discuss the pathogenesis of myocardial infarction, how the morphological characteristics of MI progress with time, and describe the clinical features of MI. So myocardial infarction is defined as the disease in which it is caused by reduced blood flow in coronary artery due to atherosclerosis or occlusion of an artery by an embolus or thrombus, and it is the irreversible damage of myocardial tissues caused because of the prolonged ischemia and hypoxia. So the main characteristics are the ischemia and hypoxia, and what happened because of the in the left coronary artery, there will be the occlusion because of the thrombus formation, and in that area where the blockage occur, especially in the acute coronary artery, the ischemia and hypoxia occur, and that leads to infarction in the entire area, and it results in myocardial infarction. So the MI could be expressed in obstruction of the coronary artery, and as a result we can see with time the changes occur in the endocardium. Initially at 0 hours there is nothing happen, not any observation, but with the passage of time the zone of necrosis occur. This light pink zone, it expressed as zone of necrosis, and then if this occur around 2 hours, and then within 24 hours this necrosis expand, and then usually patient die in myocardial infarction if it is untreated. So what is the pathogenesis of MI? The diminished coronary blood flow. That's the main thing. In example, coronary artery disease. So again, this is the same thing that explaining that this section, the coronary artery, has been blocked, and that result in obstruction of blood flow, which is known as ischemia, and that leads to hypoxia, and then death occurs. And when the cardiac muscles or the myomuscles die, then what happened that the hypertrophy of the heart occur and increase of the myocardial demand, especially in exercise and emotion. And then what happened that rupture of an atherosclerotic plaque exposed the subendothelial collagens to platelets, which undergo aggregation and activation and release reaction. So what happened that with the formation of the plaque, rupture of the atherosclerotic plaque, that expose the subendothelial collagens to adhere the platelets, and that causes the adhesion or aggregation of the platelets and activation and cause the reaction. So what happened? It can be explained in terms of superimposed coronary thrombosis, which could be intramural hemorrhage, or it could be the pathogenesis could be non-atherosclerotic cause, or it could be transmural infarct, or it could be subendocardial infarct. So the myocardial infarction depend upon the anatomical site of the blockage, whether it is transmural or it is subendocardial, which can be expressed as laminar, or it could be as superimposed coronary thrombosis, which is intramural. So we can express the pathogenesis either as intramural or as transmural or as subendothelial, or it could be because of the non-atherosclerotic causes. What are the non-atherosclerotic causes? The non-atherosclerotic cause could be either the stress-induced cardiomyopathy or coronary vasospasm, or because of the coronary artery embolism. This is a picture of the different layers of the heart wall. This is the anatomical example of the layer of the heart wall that consists of epicardium, which is the outer layer, myocardium is the middle part, and the endocardium is the inner part. Just a revision of the anatomical layers of the heart wall. And when we explain the infarction in transmural, or we can explain subendothelial myoinfarction, you can take a look that if it occurs between the layers, it is known as transmural. And you can see that it is in between different layers of the muscles. It occurs in between the myocardium, or you can say that it is transmural. Whereas in subendocardial, we have the myocardial infarction in the endocardium, on the inner layer, the thin inner layer. So if it is transmural, mean that infarction or that occlusion could be between the layers, whereas in subendocardial, it is in the endocardium of the heart. This is a picture I have not put in my slides, but it is mentioned in the textbook. And if you take a look of this picture, I can explain that when I need to explain this concept. This is showing you the right ventricle and the left ventricle, and this is the posterior side, and this is the anterior side of the heart. And what happened in transmural, as I already mentioned, that it is a permanent occlusion of the left anterior left anterior descending branch, this section. And what happened that if, for example, this is the permanent occlusion of the left circumflex branch, so this infarction can move from left anterior to the central, or you can say the left circumflex branch. Here you can see, and then if it further moves to the permanent occlusion of the posterior descending branch of the right coronary artery. Whereas in non-transmural infarction, usually which is the restoration of the flow or reperfusion, and the transient or partial obstruction will be observed, which will be found in the subendocardial infarction. It means on the subendocardial, or you can say that at the inner part of the heart layer. It could also lead to global hypotension, or it could also lead to circumferential subendocardial infarction. Why? Because again, then that infarction is in the whole circumference section of the right ventricle, or it could be the small intramural vessel occlusion, that it is only blocking only a small vessels, which can be explained in terms of myoinfarction. So again, I'm repeating the same thing, that transmural is the permanent occlusion, number one, whereas non-transmural is partial occlusion, is not a permanent. In transmural, it occur is on the usually on the left anterior descending branch, or the blockage or occlusion, or the infart will move to the left circumflex branch, or it can move to the posterior descending branch of the right coronary artery. Whereas in a non-transmural infarction, it could be either the transient or partial obstruction on the subendocardial region, or it could be a global circumferential subendocardial infarction, or it could be occur in only in small vessel, which could be explained as microinfarction. Let's discuss the morphology of myocardial infarction. The important thing you have to understand is the time frame from initially from half an hour, from half an hour to 4 hour, 4 hour to 12 hours, 12 to 24. So again, days, weeks, and months. So the gross features and microscopic features will be different with respect to time. So initially half an hour, the gross features is negligible, nothing will be there with no microscopic findings. But electron microscope, which is more powerful, can show you the relaxation of the myofibrils. And the second thing they found that glycogen loss and then mitochondrial swelling will be found. So it means that there will be swelling in the mitochondria and relaxation of the myofibrils. But if you take a look of this first half is the reversible injury section where patient can recover fast, but in the irreversible injury after half an hour to 4 hour, gross feature is negligible, nothing will be found, but under light microscope we found some wavy fibers at border. That is the key characteristics, key microscopic finding, the wavy fibers at borders. And this is the key characteristic to identify that patient having the myocardial infarction. In electron microscopy, we found the sarcolemon disruption and mitochondrial amorphous densities. So it means, as we already discussed in the first half, that in first half an hour there will be the mitochondrial swelling, but in the second half the mitochondria become amorphous, and because if it swell and then it's change in structure, or it become amorphous in structure. But if you see in further hours from 4 to 12 and 24, I'm not going to explain in detail, but you have to see that the gross features will be seen after 4 to 12 hours, where we found occasional dark mottling, which in further increase to dark mottling. Then it will further enhance mottling with yellow tan infart center, and then further increase to hyperemic borders with yellow tan softening. And then with 7 to 10 days, it become maximum yellow tan and soft with red tan margins, and then so on. When we take a look of the microscopic characteristics, we found that with 4 to 12 hours, there will be initiation of the coagulation and necrosis, edema, and hemorrhage. And if this prolonged, then the coagulation increases with the necrosis. Then pyknosis of the nuclei, and then hypereosinophilic appearance of the monocytes, hypereosinophilic appearance of the myocytes. Then we found marginal contraction band necrosis and the beginning of the neutrophil infiltrates. The coagulation necrosis increases with the loss of nuclei. As we know that it started pyknosis of the nucleus. With from 1 to 3 days, the nucleus become lost, and along with the coagulation necrosis. And then we found interstitial infiltrates of neutrophils. Then with 3 to 7 days, disintegration of the dead myofibers occur, neutrophils dying, and then phagocytosis of the dead cells at the borderline occur. And with further increase from 7 to 10 days, well-developed phagocytosis occur, and then fibrovascular granulation of tissues occur at margin. With more increase of the days, the well-established granulations and new blood vessel and collagen deposit occur, and then with an increase of the collagen deposit and decreased cellularity, and then at the end dense collagen scar will be found. So you can see that if you observe the microscopic characteristics, they will be changed with time. Begin with the wavy fibers that can express the presence of irreversible injury at that time. With the passage of time, coagulation necrosis occur, and then coagulation necrosis along with the pycnosis of nuclei, then loss of the nuclei occur, and then the further infiltration of the neutrophils, and then phagocytosis of the dead cells initially at the border, and then the phagocytosis in well developed form. So that's how this mechanism occur. So you need to know the basics of the morphological characteristics in this slide. This is a picture to show you that after around half an hour to 4 hours time, the wavy fibers, like these are the, you can say, wave-like structure, and this is a normal fibers straight at rest. And what happened that it changed to wavy fibers, and then they are separated by the edema fluid along with the necrotic cells, and if it further prevail with the time, we found coagulation necrosis and then phagocytosis. This is another picture, and this is actually more old, 2 to 3 days old in part, where you can see now not only the wavy fibers, but we also have the presence of the neutrophils. So neutrophil infiltrations also found, and then you can see the gap between the wavy fibers become more and more because of the presence of more coagulation necrosis. This is actually 7 to 10 days, where now you can see that wavy fiber almost disappeared because it is replaced by the coagulative necrosis and the presence of the neutrophils, and phagocytosis already been started. This is actually the granulation characteristic that after 7 to 10 days, what happened that if you take a look of the morphological characteristics I discussed at the end, like around 2 months, or you can say that after 2 to 8 weeks, and around we can say that after 2 to 8 weeks, there will be increased collagen deposit, decreased cellularity, and dense collagen scar. If you take a look around 7 to 10 days, I changed the color. Yeah, this around 7 to 10 days, we mentioned the formation of granulation, fibrovascular granulation tissues at the margin occur, and then 10 to 14 days, this granulation will become well established. So then if you take a look of these microscopic characteristics, you can take a look of this slide, and you can see that the granulation tissues by loose connective tissues and abundant capillaries. This red structure, the red small and big, are showing you the presence of abundant capillaries, and they are expressing along with the loose connective tissues. We can stain with blue collagen. So you can see the blue color. The blue color is showing you the presence of the loose connective tissue by staining with meson trichome stain, which is used for staining the connective tissues, especially the loose connective tissues. And you can see further on, if you see if this proceed for months, you can see that dense collagen scars. We can see that the stain with the blue color that is showing around here is showing you the presence of this all structure is showing you the presence of healed myoinfarct, which consists of dense collagen scars. How can we diagnose? I already mentioned that ST segmentation changes are very important, and if I discuss in my previous slide, I go back and I'm going to explain. There will be increase of the ST intervals in transmural, whereas in the subendocardial, the ST interval is not enhanced. So you can see that the ST interval can be helpful for determining the type of the myocardial infarction, or we can find out through Q waves or T wave inversions. And the other way to identify or to diagnose the myocardial infarction is to see the level of myoglobin, cardiac troponin, T and I, and then creatinine kinase. These all indicators are helpful for identification of myocardial infarction. This is the picture of normal electrocardiogram, and this is, we can see that to express our heartbeats, which we have the Q, R, S, then we have the T, and then the interval between them can be expressed as QT interval between Q and T, this Q and this T, or the segment between S and T, so that is expressed as ST segmentation. So these between both of them is R interval, and it can be explained, the myocardial type of myocardial infarction can be expressed in understanding the normal electrocardiogram by comparing the normal electrocardiogram with infarct electrocardiogram to diagnose which type of infarction occur. The clinical features is consist of severe crushing substernal chest pain or pressure that can radiate neck, jaws, and epigastrium or left arm. And if you take a look of my case that I presented initially, we mentioned the important thing is that the pain is central, radiate up to the jaws. So if you read this statement will help you to identify the patient having the myocardial infarction, and I'm going to see the clinical symptoms. So you can see that it radiates to neck and jaw, epigastrium or left arm, and they have atypical signs and symptoms, may even entirely sometimes asymptomatic. So that is very important because patient don't know that he is having the infarction. So it is very difficult because the clinical biomarkers such as using I discussed before that creatinine kinase or cardiac troponin T and I or myoglobin is practically it is very difficult because it take time to diagnose. So usually people don't usually the physician rely on the clinical symptoms or electrocardiogram. Actually, the fastest way to identify the myocardial infarction is electrocardiogram, as we have to understand that patient having very short time. And if you take a look of morphological characteristic, it changed very quickly from few minutes to few hours. So it means that the laboratory findings is irrelevant, and then we need to see the clinical features or more focus on the electrocardiogram. And we mentioned here at the end that such silent infarcts are particularly common in patients having diabetic mellitus. Again, this is very important. If we take a look of the silent infarction, especially occur in diabetes mellitus. Why? Because patient having neuropathies, and because the neuropathies may prevent the perception of the pain, especially in elderly patient. And then in that case, patient does not feel the pain, and that is why they are considered silent infarction, because patient having the infarction but he is not feeling any pain. But myocardial infarction, with passage of time, it can grow worse and worse because it is an irreversible form of injury. And then you can see that how much it is life threatening. So thank you so much for today's lecture. Hope to see you again in upcoming lectures. Thank you.